This is a case where the core has a deep margin. We're treating the lowest 6. So first we're going to isolate with a slot technique so that we can remove the interproximal contact and then gain access to the tissues that need to be removed. We're using a thermocut burr with no water, and we're just going through it and removing the excess tissue so that we expose the margin of the tooth structure. Now what we're thinking about here is that we want to be able to get a wedge into the interproximal area that's going to sit down below that margin. So we have to remove the buccal and lingual papilla as well. Now once we've done that, we re-isolate with individual holes, and then once we get the dam in place, we place a wedge, and this is going to help push that rubber dam down and compress the tissues in the interproximal area, and that's going to help with isolation. So you can see how we've temporized the tooth. We've got a GIC overlay, so we're going to remove that, or some of that now, in order to gain access to the root canal. We're removing the coronal part, the overlay part first, because our measurements during the initial root canal treatment were taken from the tooth structure before the temporary was put in place. We've got cavit or tempit in this case, just inside the pulp chamber, and we're removing that with an ultrasonic and water. So that removes pretty easily. So now we have nice isolation for our obturation procedure, and once we've obturated, we can then go on and remove the remaining GIC. And you'll see we made a mistake here in the way that we set the case up, in that we're relying too much on the wedge to isolate the tooth at this point. And so you'll see once we've removed all of the restoration, we basically prep this for an onlay. Once we remove that wedge, we can see that the rubber dam pops up over the margin. And so we're now going to place some retraction cord. You can use normal retraction cord with some sort of astringent end or viscostat, something like that. And we're going to pack that down there, or you can use Teflon. We probably should have done that before we placed the wedge right at the start of the procedure. But regardless, we're going to manage it now, and you can see that we now have our sectional matrices in place. An alternative would be to use a Toffelmeyer if we think we're going to manage to get the margin down there and the contact's okay with it. I guess the benefit of the sectional is that we have a little bit more control over the shape. So you can see we're burnishing it here, and there's a little gap between the tooth structure and the sectional matrix. And so we're going to pack some Teflon down into that area and push the matrix back against the tooth. So we're using DC core total etch technique. We'll snap some photos, and we're going to use cavity cleanser, so that's chlorhexidine, and the normal bonding protocol for DC core. We scrub that well into the dentine. And this is a Centrix tube with the DC core in it. So that's the aqua tube, which is the thinnest tube. And we run that down into the pulp chamber, and the very deepest layer I tend to use a probe just to run around after that and make sure there's no air bubbles in there. And often we end up finishing off with an orange tube, which is larger, and we can express more of the DC core through. So the DO will be ready for that. And just making sure that's held nicely. We leave that at least 2 minutes before we light cure. And this, in this case, we're going to leave the tooth with the core for 3 to 6 months before the tooth is getting its final full coverage restoration, or at least onlay, indirect onlay. And so we're just going to trim that back and give it some basic anatomy. It's going to be cut away eventually. So we've overfilled that, and then we trim it back to the margins. So we'll give that a little polish as well, but we want full coverage to protect the remaining tooth structure. And you can see there how deep that the margin is, so it's quite close to the bone. So an obvious alternative option would be crown lengthening surgery, but this way is a little bit faster and a little bit cheaper for the patient. We'll typically leave that 2 to 3 months for the papilla to regenerate, and we'll issue the patient with interproximal brushes and also chlorhexidine to use in that area for the first 2 weeks. And then after that, they need to continue using the interproximal brushes to make sure that that gingiva recovers and is as healthy as possible. And you'll actually see, as long as there's a contact point there, you'll see a reasonable amount of gingiva regenerate, and the indirect restoration will then be able to be fitted according to that gingival profile.